So we are very fortunate to have Professor Dr. William Powderly here to give grand rounds today. So he's the Dr. J. William Campbell Professor of Medicine and the Larry J. Shapiro Director of the Institute for Public Health at Washington University in St. Louis. He is also the co-director of the Division of Infectious Diseases at the Washington University School of Medicine. From 2005 to 2012, he was Dean of Medicine and head of the School of Medicine at University College Dublin in Ireland. Dr. Powderly has been actively involved in HIV-related clinical research for 30 years. He has been a member of numerous advisory groups on HIV and infectious diseases for the NIH, the CDC, the Canadian Institute for Health Research, and the European Medicines Agency. He is the author of over 400 original manuscripts, reviews, and book chapters. His recent focus as director of the Institute for Public Health has been on translating scientific advances to a wider population to improve public health. The Institute, under his direction, has focused on implementation, science, community partnerships, economic and policy research, and global health to broaden the impact of discovery science and address disparities in health outcomes. He is a fellow of the Royal College of Physicians in Ireland, the Royal College of Physicians in London, and the American Association for the Advancement of Science. And in 2017, he was the president of the Infectious Diseases Society of America. Please join me in welcoming Professor William Powderly for his talk.
Good morning, and thank you. It's a pleasure to be here, and thanks for the invitation. Let me start. These are my disclosures. Nothing is relevant to today's talk. So most of you know, have heard something about precision medicine. The Precision Medicine Initiative through the NIH was launched a couple of years ago by President Obama, and it really is an initiative to try and take what we're increasingly learning from omic science, genomics, and so forth, to understand individual variability, and from that to allow us to tailor individual treatment for patients. Better understanding of biologic pathways to design drugs more effectively, and better understanding of risk to understand what the true benefits and risks are for any form of therapeutic intervention. The drivers are twofold. One, the incredible explosion in omic technology and the ability to do this in a relatively large scale for increasingly lower cost, and an explosion in informatic technology that allows us to assemble all this information and at least understand it in a better way. And there's tremendous interest in this, simply in part because we all recognize the heterogeneity in treatment responses among patients, and trying to understand that in a better way would obviously improve our ability to look after patients. At least that's so we think, and certainly we waste a lot of money giving ineffective therapy and ineffective interventions to people who do not benefit from them, and that is very true in multiple cases. So this is essentially using what we've seen externally in terms of data analytics to start using it to the benefit of patients. And it holds great promise, there's no doubt about that. It's driven in large part by the fact that we can sequence genes much more rapidly at lower cost, and I think everybody who's been involved in this realizes that this has the perspective or the potential to be beneficial to many different populations. For patients, identifying of an individual disease risk and more targeting prescribing would be obviously beneficial. For providers such as us, making better decisions, and in particular making decisions about whether drugs are effective or not effective. It's theoretically beneficial to payers, and there's no doubt that it has great opportunity in terms of discovery science, particularly in the ability to identify new targets, and as I'll show you in a moment, it's the potential for doing better clinical trials. The opposite of precision is imprecision, and we do practice imprecise medicine. There are many drugs that we give to patients now where we know that a significant proportion of patients will not benefit from those drugs, yet we don't know which patients. So we give it to everybody in the hope that we can identify reasonably early on whether they will benefit or not. I think oncology has really benefited enormously in the last few years from this change in perspective. Those of us who are a little bit grayer learned our pathological classification of cancers based largely on the visual appearance of a cancer. And so, as a consequence, cancers were linked much more by organ and by what they look like under a microscope. Increasingly, we're recognizing that the drivers for cancer are mutations that can be shared across many organs. And those mutations, by targeting those mutations, one can lead to perhaps a much better way of classifying cancers and therefore classifying responses to cancers. And this leads you to a much better way of potentially doing clinical trials. Clinical trials on the basis not on whether this is a lung cancer or a gastric cancer or colon cancer or breast cancer, but on what are the mutations that are driving this particular cancer. Can therapy targeted at that mutation or that cluster of mutations lead to a better response? And this has led to many more cancer trials leading to the natural hype that cure is around the corner. And perhaps it is, although it's been around the corner for quite some time. Those of you in the HIV field will remember that Margaret Heckler, who recently died, was the Secretary of Health in 1985 and promised a vaccine for HIV in 2 years. So politicians' hypes don't always come true. But there's no doubt that what we're looking at is the ability to put a huge amount of data into a system that will give you potentially greater outputs. And it does require a really robust informatics system. We've looked at and we've talked about the explosion in the technology to allow us to look at genomics, metabolomics, the microbiome, but really this would not have any value to medicine if it wasn't for the fact that we also have an enormous enormous ability to start putting that data together and work closely with people in informatics to try and make better associations and understanding. So, the promise of a brave new world. That's what we're facing, a truly revolutionary time in medicine. Disruptive technology coming in at a time where we can potentially offer our patients something extremely different. So the question and what I want to focus on is whether, if precision medicine works, and I'm going to work on the assumption that we will actually get benefit for individual patients from the enormous investment in precision medicine, whether that will improve the health of the population. There's undoubted likelihood that we will see individual benefit. That an individual patient with a certain type of cancer or a certain type of inflammatory condition or a patient who needs modulation of their immune system can potentially benefit from a better understanding of the pathophysiology and targeted therapy. The question really, though, is that going to do anything for the health of the population, and particularly the health of the United States? So let me bring you back a little time in history and talk a little bit about the evolution and where we are with HIV and AIDS, because I think it is a good object lesson for the promise of discovery science, what we can actually deliver when we have scientific investment into the pathophysiology of disease, targeting treatment, and getting benefit from that. and the challenges that remain even when we have that. And then we'll discuss whether or not the lessons from HIV/AIDS are pertinent to our current situation. So HIV and AIDS is a new disease, first described in 1981. So within the lifetime of at least some physicians in the room. And it rapidly became one of the most devastating and important epidemics worldwide. To date, about 80 million people have been infected worldwide, 40 million of whom have died. By 1994, in the United States, HIV/AIDS was the leading cause of death in adults between the ages of 20 and 44. It surpassed all other causes of death at that time. And as you see from this graphic, it was inexorably rising year by year. There was no change. There was nothing that was really being done in spite of a lot of work and a lot of challenges. And for physicians at that time who looked after people with HIV, it was somewhat depressing, because it is hard to be a doctor when all your patients die. But that period, that 14 years between the discovery of the description of the syndrome and the ultimate discovery of targeted treatment, was not a fallow period in terms of science. There was an enormous amount of investment in science, in the science of HIV, at a genetic level, understanding the genome of the virus, at a structural biology level, understanding potential targets. The virus had some simplicity. It had essentially only 3 enzymes that mattered, and all 3 became targets for antiviral therapy. And an enormous amount of investment, as I said, went into that discovery science, an investment largely funded by the US taxpayer. That culminated in 1996 with the introduction of the modern era of effective antiretroviral therapy. And you can see from this graph that the effect was dramatic. And for those of us in the field at the time, it was a remarkable year. You went from having an inevitably fatal illness to having a potentially controllable illness overnight. And you could see it in your clinics. And that has progressed. Let me say that this is an early example of precision medicine. What we're being precise about is targeting the viral genes rather than the human genetic variation. But we have the ability, and so 20 years before the modern era of precision medicine, antiviral therapy for HIV was essentially the same thing. The advantage was the virus had only 3 genes, as opposed to the human genome. And all 3 genes had been fully sequenced, and variations in those genes could be understood, particularly in terms of mutations and their ability to be resistant to antiviral therapy. So it was possible in the vast majority of patients to tailor a treatment that was targeted to that patient's virus, precision antiviral therapy. And there's no doubt that it has been dramatic in its effect. If you have a 20-year-old who comes into one of the clinics here with a newly diagnosed HIV, you can essentially tell that person that if they take their medicine, that's a big if, but if they take their medicine, which is now 1 pill once a day, they can expect a normal survival. It won't protect them from being hit by a bus trying to cross Madison Avenue, but it will mean that they should not die of HIV infection. And that is quite remarkable. So we have gone from a universally fatal illness to a potentially controllable illness that does not affect lifespan. It has myriad other effects, but as best we can tell from a large number of cohort studies, the average survival of an HIV-infected individual treated early in the infection is projected to be at least a year longer than controls when you look at European cohort populations. So, it's a paradigm for translational medicine. In 1981, we knew nothing about this, absolutely nothing. It's interesting to go back and read the New England Journal of Medicine from that time and see all the speculation that was as to what the cause might have been. But by now, we have changed the natural history of this infection, dramatically decreasing both its morbidity and its mortality by true application of translational science, understanding its molecular pathogenesis, developing structure-based therapies, and developing evidence-based clinical protocols, all of which led to the elimination of perinatal transmission in the developed world and survival of an HIV-infected individual in the developed world being as close to normal. We have about 20 million people now on antiretroviral therapy out of the 39 million or so infected worldwide, and the effects have been dramatic. So, do we declare victory? The problem is that we have now a chronic illness with all the problems of chronic illness in modern medicine. So this is an interesting way of looking at any chronic illness. What we call the continuum of care or cascade of care, which was for HIV, which was described first about 10 years ago, and really looks at the total population and asks how many of them are actually at the point of getting the best possible treatment. So you have the target for HIV is that the virus is suppressed. If the virus is suppressed, the patients don't have any progression in immunodeficiency. In fact, their immune system will recover. And if the virus is completely suppressed, by and large, the consequences of HIV are minor for that patient. However, only 50% of the US HIV-infected population has viral suppression. So that means half of the people with HIV infected in the United States are not controlled, in spite of the fact that we discovered as a nation, we invested in the science, and we discovered as a nation the control and developed the approach to this 22 years ago. So 22 years after the introduction of a precision medicine approach for HIV, we only have half of the people in the country. For some, they haven't been diagnosed. For many, it's that they are not receiving care. How do we compare to other places? Poorly, if we compare ourselves to countries we would regard as peer countries in terms of their economy. In Western Europe, as you can see, they are doing much better. In fact, we look much more like Central Europe. We much look like Poland and Hungary and Romania and Bulgaria and Turkey. So why is that? Well, the barriers to successful HIV care are myriad, but they can be summed up into two major issues. One is a lack of access to services, in spite of the fact that HIV is one of the few diseases in this country where there's a federal program that actually pays for medication. And issues related to the social determinants of health. So is HIV unique? This is a complicated slide. But what it tells you is two things. So on what you see on the horizontal axis is the health spending per capita. And here is life expectancy at birth. And if you go back to the 1970s, the United States was pretty equivalent to most of the OECD equivalent countries. But something happened around 1980. And since then, our costs of healthcare, our spending on healthcare per capita, have risen dramatically in comparison to the rest of the world. It's been rising. While the difference between life expectancy in the United States at birth and that of much of the rest of the world has widened. So something has happened to healthcare in the United States that had meant that at a population level, not at a personal level, but at a population level, we're going in the wrong direction. So this is St. Louis. This is a study that was published about 3 years ago, and I realized you don't know the geography. This is the Mississippi River right along the, so we're looking west from the Mississippi. Washington University is located right around there. And in the zip code just around Washington University, a man born in that zip code has a life expectancy of 85 years. You go 5 miles east, just north of the downtown, and a man born there has a life expectancy of 67. That's an 18-year difference in a 5-mile. And this is no different from many other places in the United States. And that really is the question that I think is a fundamental question if you're going to ask whether we can achieve the issues in terms of population health that we think we might be able to do with better discovery science. So it's not just me who tells you this. This is a report from the Institute of Medicine, and it's well worth reading. And it points out, as I've just shown you, that America's health is worse than other high-income countries. We have the highest infant mortality of any of our OECD peers. And even advantaged Americans, which is really is people in this room, people with a college education who have health insurance, have higher incomes, and by and large have healthier behaviors. Even they, when they're compared to their peers in other high-income countries, aren't doing as well from a health perspective. So, why? Well, the IOM felt there was a number of issues. One was health differences in health systems. Most of the other OECD countries have health systems. We don't. We either have none, depending on your perspective, or we have 120, but neither is an efficient way to deliver healthcare. Health behavior, socioeconomic conditions, and the physical environment. And in particular, the issues around social determinants of health are crucial to a population's health. This is the CDC definition of social determinants, and I think it's a really important consideration because when we look at precision medicine and think about what it can offer us, we have to stand back and say, what degree of the differences between outcomes are driven by the genes, and therefore if we intervene based on our understanding of the genome and variations in the human genome, how much of a difference can we make? Well, the current estimates is about 30% of the differences in outcomes in health in the United States are driven by genetic variability. I mean, 70% are not. And the major driver of those differences are the social determinants. Access to healthcare, access to resources, education, employment, poverty, insurance coverage, housing, racism, segregation, transportation. You see it every day in your clinic. Anyone who has a clinic of any variability will see differences in outcomes based on these things and not based on the underlying biology. The underlying biology is affected by these. There's no doubt there's an interaction between the genetic environment and the physical environment and the social environment. There's no doubt that epigenetic changes over time are important in the expression of diseases. But nonetheless, by ignoring this, we were on the major risk of not addressing, not delivering the promise of precision medicine to the population that fundamentally is paying for it. Remember, most of the science, most of the discovery science is funded by the US taxpayer. And so the return on that investment can be multiple, but one of the returns ought to be that it leads to the improvement in the health of the US population. The major causes of premature death in countries like the United States continue to be diseases that are driven by lifestyle. There may be a fundamental genetic predisposition why somebody who smokes gets lung cancer and some people who smoke don't get lung cancer is undoubtedly driven, at least in part, by a genetic predisposition. But the major diseases that we see causing death, premature death, and therefore those that would affect the outcome from a population level are driven by lifestyle. The other way to think about how you make a benefit in terms of population health is to target diseases that affect children. So, because when one calculates premature death, a death at the age of 6 months counts much more on a population level than a death at the age of 75. So if we target diseases that are major causes of premature death in children, then we could potentially affect population health on a broad scale. People have pointed out that if we developed vaccines for cancer, for example, and we're able to prevent cancer death, even if we can't prevent those cancer deaths in middle age, we'd have a profound effect. The interesting thing is that we have a vaccine for a cancer. The Hpv vaccine is essentially a cancer vaccine. The discovery of the Hpv vaccine is a joint Australian and United States accomplishment. Much of the work came from research funded either by the US taxpayer or US pharmaceutical companies. The uptake of the Hpv vaccine among young women in the United States is terrible. It's about 40%. In certain communities, it's less than that. Australia has had universal Hpv vaccine for girls since 2009 and for boys since 2011. Next year, Australia is eliminating the need from a public health perspective for regular pap smears in women. So, we invent the technology and then we don't use it. So what, if like me, you've been thinking about the intersection between discovery science and public health, the concern is the fact that new technologies, although potentially wonderful for an individual patient, have a true potential for widening disparities. Because if we do nothing to address the reasons why many of our patients are not benefiting from the science we already have, why do we think that introducing new science will change that? So what we could do, what we can do, is to try and use this emerging information, particularly at a data level, to develop a better understanding of the determinants of health at a population level, even and not at a full population level, but at a micro-population level. And combine both population-based and individualized interventions to improve population health and try and narrow health disparities. Public health is really messy. Anybody gets into it realizes that this, you can throw your hands up and say, God, this is impossible. And it is difficult. The disparities that we talked about and I showed you are true all over the world. Even in the most progressive countries that have very strong safety nets, you will still see differences by income and by education in health outcomes, but none as wide as we see. And so, broadening and reframing precision medicine beyond the omics and bringing it in, start thinking about precision approaches to social, behavioral, environmental factors will give us the potential to making this difference. And really what I am suggesting here is that in precision medicine, we very much focus down on the individual. We're trying to find the biology in that individual, understand their health, and improve their disease. And that is natural. We're doctors. That's what our training has been, to look after the patient sitting in front of us in the office or at the bedside. But in order to really deliver more effective health care to that individual, I would argue that we need to actually step backwards as well and understand that individual in the context of their family, their community, and the social, environmental, behavioral factors that have driven them to get to the point where they are now seeking our attention, and to start thinking about what we can do to prevent some of that. And if we can combine those approach, not only have the application of modern technology at the individual basis, but also at the population basis, then we have the potential to make these changes. So there are issues. I think most of you know that most of the existing genomic based therapies use data that's largely derived from populations of European descent, and we need to have much more research to look at different populations, both within our own society and in other societies. But part of that is also we need to actually engage the populations that have been missed in the research endeavor. And that means overcoming issues of literacy and understanding, but also overcoming legacies of distrust and being advocates for improvement and access to care. It's an interesting reflection that if you want to do major research funded by the US government, say HIV research in a vaccine, in the developing world, in resource-poor countries, part of the negotiation that has occurred is that it would be unethical to do that research if you cannot offer the results of that research to the populations in whom you're doing the research. And it is an accepted ethical principle now that if we do vaccine research in developing countries, that part of the deal is those vaccines will be made available to those countries at a cost that is affordable. So we've accepted the ethics of that, doing that in developing countries. Why is that not an underlying fundamental ethical concern for doing research in disadvantaged populations in our own country? The other thing is that we have to start paying attention to the phase after discovery. So we've talked about that precision medicine will offer us the promise of delivery to the payer anyway, of getting rid of waste and inefficiency and suboptimal quality. But this is an enormously interesting statistic that has been borne out by multiple levels of research. And that is that on average, most original research doesn't have any advantage to patient care. And when it does, when you do a clinical trial and you show something is beneficial, how long does it take that to get into the DNA of doctors who are prescribing medicine? It takes on average 17 years. Why is that? Most people practice the medicine they learned in residency. So let me take you another example of where I think our thinking ought to be. So there's a lot of promise, the prevention of colon cancer, a lot of work being done on genetic conditions that predispose people to cancers, and learning from the lessons from breast cancer. The Lynch syndrome is a syndrome that accounts for about 1 to 3% of colorectal cancers and associated with specific mutations. Current guidelines suggest that all newly diagnosed colorectal cancer patients be offered testing for Lynch syndrome in order to identify the causal mutation, and then test their relatives. And if they have, and those relatives should be screened earlier for colorectal cancer, beginning at an early age, and more frequently in the general population. Okay, Dave, sounds wonderful. So, what would it take to implement that? And how could you ensure that there weren't disparities? Well, think about it. It says people should be tested for genetic testing. So that means you have to have it available. It has to be available for everybody. They have to understand what it means. You have to be able to counsel people appropriately. But even then, it calls not for an immediate colectomy. It calls for a colonoscopy. Is access to colonoscopy freely and readily available to all populations? So if we talk about this wonderful new preventive technology that will allow us to prevent colorectal cancer, and we do nothing about thinking about access to care and thinking about how to implement it, how to actually do it in a population, particularly in a population that already has certain disadvantages. Why do you think that it won't actually make those disadvantages and disparities worse? And why do you think if you talk to those populations and ask them to participate in your research and then say, well, what's the benefit for me and my family, that they might not be a little bit cynical about it? So when we think about discovery science, we really have to think about how we're going to actually deliver it. And that means we also have to invest in a wider variety of translational science that we have not invested as much in as we should have. And the reason for that is discovery science is sexy. You know, you discover a new gene, you're likely to be, highlighted by your university's PR people. You may even make the New York Times. We read the Times in the Midwest too, so. Whereas if you actually figure out how one side of medical system can actually deliver this to its population, you'll get a pat on the back from the chairman, but that's about all you get. But it's, in terms of delivering it to people, it's as, if not more important. So we need to really start thinking about what are the things that we can do to understand these factors, and can we intervene upon them? Because that's the big issue. Can we make a difference? Because otherwise you say, as a clinician who's not a public health scientist who now runs a public health institute, and I'm a clinician, a clinical scientist, one of my greatest critiques of public health is they've been wonderful at telling us what's wrong, but not so good at telling us how to fix it. And as clinicians, we don't want to be told what's wrong, we want to focus on solutions. So let me give you an example of an approach. It's well recognized that minority populations suffer more from asthma in inner cities than Caucasian populations. This is PCORI data looking at hospitalizations and deaths, and you can see that there are dramatic differences between the need to go to the emergency room, the utilization of the emergency room for asthma care, and the risk of dying from an asthma attack. The pediatric pulmonary group at Cincinnati has done a lot of really interesting work on the relationship between the social determinants of health and asthma morbidity. So what you see here is, on the top are asthma emergency visits and hospitalizations for the Cincinnati census area. And then they map them, psychosocial environment, crime rate, poverty, housing code violations, and areas that were regarded as medically underserved. And you can see that these things tend to follow one another. And this is the hospital, and this is focusing on the correlation between asthma visits to the emergency room and housing code violations. And housing code violations being a good marker of the physical environment. So they figured that a major driver of asthma incidence in these hospitals was poor housing quality. But they didn't stop them just describing that. They were doctors. They said, what can we do about it? So they developed a partnership with the Legal Aid Society. They brought it into the hospital to allow families to gain access to legal advocates who could hold landlords accountable. And now in the Cincinnati Children's Hospital, on their Epic, you can consult the legal aid service just like you're consulting ID. You just put in a consult and they come to the family in the hospital and they'll start and referring patients. And they can even refer directly to the Cincinnati Health Department to send home inspectors to address housing concerns. Now, we don't yet have enough data from their intervention to know if this intervention will have a major effect. But it has been interesting enough that there is a coalition of 10 or 11 pediatric hospitals around the country now doing this as an intervention trial funded by PCORI to see if this combination of the medical intervention and a social intervention derived at the conditions that are driving the medical intervention, the medical condition, can make a bigger difference than just treating the asthma event yet again, because that was the frustration for the doctors. So it's partnering with communities and partnering with them properly and making it a partnership. One of the problems that we've had is many people who've engaged in community-engaged research have been academia going out into the community and telling the community how to solve the problem. There are smart people outside. The need is to work with them and work with them as a partnership, and making the partnership lasting, because one of the great criticisms of academic institutions is they come, they do their study, and they leave. And if we're going to make things like this work, we have to partner with people. This is a really big change, if you think about it. So we have focused as physicians and institutions on patient-level determinants. So we look at issues around service utilization. We have health insurance navigators. But if we start to get into community-level determinants and household-level determinants, we're talking about a partnership that's outside our comfort zone. That's quite different from what we have done typically as physicians, and as hospitals for that matter, or healthcare systems. It raises a question, should health systems actually take responsibility for the population that they serve, not just for their medical needs, but for the needs that drive those medical conditions, for the social determinants? So that's a big question for hospital administrators. And I've had that question put to me, why should I put our hard-earned dollars into improving the outcome? Now, they will put some of their hard-earned dollars into things that they think matter, like reducing 30-day readmission rates. But, you know, it's a harder thing. And this is the problem that we face in the United States because we lack a healthcare system. Because we lack a healthcare system that's actually focused on what are the systematic needs of the population of the United States. Or even the state of New York, for that matter. If we had 50 healthcare systems, it would be better than the mess we have right now. So we spend $4 trillion a year. Can you make a case for allocating money like mold-free housing and safe neighborhoods? Is that healthcare? There is a way of measuring it. A return on health. And it is a measure that other countries have started to use to try and look at how you address social determinants and how you use healthcare dollars to look at prevention of chronic conditions rather than waiting for them to develop. The problem is it's a long-term intervention, and it requires long-term thinking. And long-term thinking is really, really hard because everybody wants the immediate payoff. So let me very quickly, and actually I'll tell you what I won't. I was going to say a few things about global health, because this equally applies to global health, and actually the Gates Foundation is investing quite a bit in a precision approach to global health. I'll show you one slide that comes from the Gates Foundation. It was published in Nature last year, which showing that actually if you target a couple of areas, using our understanding now of the biology and also the mapping focused target on Aedes aegypti, which transmits a lot of the arboviruses that are significantly associated with disease, could actually eliminate 90% of the disease burden worldwide. And that really comes from a global mapping project that Gates did. But I really just want to conclude and give you an opportunity if there are any comments or questions. So we can enhance public health in the precision medicine era, but it requires, I think it requires a reboot, a rethinking of what we want to do. We have to work with people to help them understand what we're talking about, identify research priorities, and develop implementation programs in parallel with the research we're doing, so that we don't have this 10 to 15-year wait to see the benefit. And to start thinking about the issues, particularly in disadvantaged populations, about what could we do to actually implement these things more rapidly. We need to get integrated healthcare systems, and increasingly we have integrated healthcare systems. I work in a system that has 19 hospitals, covering about 10 million lives in the eastern Missouri and southern Illinois. A major academic medical center and a lot of smaller ones. But to think about population health and social determinants. And to share lessons locally, and work and trust people to understand what the needs of their communities will be, and work with them. Translational medicine is a journey. And to bring you back to the HIV story, those of us who've been in this journey have gone this entire road. It starts with so-called T1 research, moving laboratory findings to clinical solutions in humans. And then into clinical trials, testing hypotheses and doing human trials. We then have to bring that to practice and to populations, so-called T3 and T4 research. One of the challenges I would put to you is that the institutions that have been dedicated to discovery science, places like Washington University in St. Louis, places like here, have focused on T1 and T2. And I would argue that it is not acceptable to say that it's someone else's job to do the T3 and T4. We have a lot of smart people working in our hospitals and our labs. There's no reason why we can't take the whole journey and deliver a true change for populations. I think it's the ethical thing to do and the right thing to do, and I think for most physicians, when they think about what they really want to accomplish for the patient that they're looking after, is that that patient will be healthier, and that patient's family will be healthier, and that patient will have a longer life that is productive and beneficial. So I'll just conclude and thank you for your attention.
comments. Yeah.
So if I recall the MacArthur study on successful aging correctly, 70% of disease in infants and young children is genetically related, and 30% is environment. And it's just the flip, the 30% you quoted in middle-aged and late life.
Yes.
So all of this money in precision medicine and genetics is much more likely to benefit my grandchildren, but certainly none of the gray-haired people in this audience, and perhaps none of the people who really have less than gray hair. That is, the ROI will benefit, the ROH will benefit grandchildren and other generations rather than us.
So I think there's two ways of looking at that. I mean, and I want to be very clear. I'm not a Luddite. I mean, you know, I looked after HIV-infected patients in the era when we had no therapy. And I was involved in the early clinical trials, and I remember what they were like. I remember the excitement that we had when we actually were able to offer people treatment. And I think for the 50% of the US population that's on treatment and they're getting effective treatment, their individual health has benefited enormously. So you will have, at an individual level, there is undoubtedly true that at an individual level, there will be people who will develop a disease 5 years, 10 years from now, who will have very effective therapy that they wouldn't have now. So I think we should not dismiss the value of that. You will have people who will live to see their grandchildren, who would not have lived to see their grandchildren. And that, you know, as a physician, I'm not going to say that we should stop and do any discovery science. Absolutely not. The question, I think, is, can we have both? Can we have our cake and eat it? And I believe actually we can if we properly think about this and think it through and think about what delivering the true promise and making sure that populations that are currently being left behind or not having advantage of the technologies that we have developed already will not actually be further left behind when we develop new technologies. So I think you're right in one sense. And I mentioned this earlier, the likely greatest benefit of precision medicine in terms of population survival will be those that make a difference in children. But I wouldn't discount the benefit of taking somebody who currently has lupus nephritis and, you know, faces an uncertain life expectancy as a middle-aged woman, and being able to say that that person could live into their late 70s or 80s and see their grandchildren grow up. I think that's actually, you know, that's what drives many of us.
Thank you for your wonderful talk. Do you think in the case of the HPV vaccine, and in many cases in this country, the political and religious interference, or, you know, since 1980 that we can pinpoint somebody in government, that affects, and that can be a huge difference with other places?
It's an enormous issue. I mean, in retrospect, the CDC made an enormous mistake with the HPV vaccine. They targeted it initially, and they talked about it initially as a vaccine to prevent an STD. And of course that raised enormous political objection among certain circles that it would increase promiscuity, which was the nuttiest thing from a scientific perspective, because they're saying, I don't believe this. But it did. In other countries, they immediately promoted it as a cancer vaccine. So, you know, get your daughter vaccinated, she won't get cancer. Much better than get your daughter vaccinated, she won't get an STD. Well, my daughter will never get STD, she won't have sex. So, I mean,
I know people that vaccinated their boys and not the girl.
Well,
Okay.
I vaccinated both my boy and my girl. So, you know, so yes, the political environment in which we are, and I think we have an incredible challenge at the moment. The anti-scientific culture that has arisen, particularly in the United States, but it's not unique to the United States. I mean, you just look at the vaccine nonsense going on in Italy at the moment. But that culture of almost directly focusing on science is something we have to overcome. But we have. Who else is going to challenge that except us?
Just a question. Last one.
So you showed us that it makes a difference where you live within St. Louis and in Cincinnati. But I really want to focus more on the entire United States. We have states that are progressive, states that are conservative. Some have given more support to accountable care organizations, some less. Some have expanded Medicaid, some not, in both conservative and progressive areas. So can you tell us, with support of these public health organizations, has it made a difference, and specifically in relation to precision medicine, since that's what you're talking about?
So the short answer is to that is that it certainly makes a difference in terms of access to healthcare. There are some small studies that have shown mortality benefit. There's absolutely no data with regards to to precision medicine as we were talking about it, because it's too early to really know. Major interventions in terms of, let me put it this way. There's good data in the United States that, in general, your health is better in blue states than in red states. But there's much more poverty in red states, so you have to try and figure out what is driving what.
Thank you very, very much.